Right, hello. Hi, everybody. We're doing something a little bit different today, and that is reacting to or reading a bit of documentation that's been published. My name is Ollie. I'm a doctor living and working in London currently as a clinical research fellow in neurosurgery. And this, as you might be able to see, is the Physician Associate Title and Introduction Guidance for PAs, Supervisors, Employers, and Organisations, published by the Faculty of Physician Associates from within the Royal College of Physicians, the RCP. Now, as you will no doubt know, there has been a lot of ruckus, furore, dare I say, brouhaha about the role of physician associates in the UK NHS, what that might look like, what it currently looks like, where it might go. There's a lot of unknown unknowns, basically, and to see any kind of clarity, especially published by a central body that is involved setting the scope of practice and oversight of PAs, like any documentation and oversight is a good thing. So I thought it would be a good chance to go through this, have a read of it. It's not a very long document, it's only 4 pages, so we'll go through it together and see what we can make of it. So, the Faculty of Physician Associates has created this guidance to provide clarity around the role of physician associates. Good. Provides practical examples of how physician associates should describe their role and is aimed at increasing understanding of the patients, employers, other healthcare professionals, so that might include doctors, and the public. So, who are they? Physician associates are healthcare professionals who work as part of the multidisciplinary team, the MDT, under the supervision of a named doctor, which must be a General Medical Council registered consultant or GP. That's something interesting to pick out at the beginning, because this actually misses out or doesn't make reference to specialists, which are the other type of recognised independently practicing doctors who form part of the SAS grade doctors. So just as much as you do have consultant doctors and GPs, these are people that have completed the national training programs and gotten their CCT in a particular specialty. Those doctors are being highlighted as the ones who can supervise physician associates. It's interesting that they miss out SAS doctors, so SAS specialists who can also practice independently just as consultants can in a given specialty. While they're not medical doctors, PAs can assess, diagnose and treat patients in primary, secondary and community care environments within their scope of practice. Now again, we'll see. I don't know whether scope of practice is going to be addressed in this. It probably isn't, but the lack of scope of practice and the lack of a defined scope of practice is one of the things that's leading to a lot of problems with the employing of physician associates and how they relate to other healthcare professionals. So MAPS. PAs are part of NHS England's MAPS workforce grouping. So MAPS, medical associate professionals, for those unfamiliar, include physician associates, PAs, anaesthetic associates, AAs, and surgical care practitioners, SCPs. PAs have been part of the healthcare workforce for 20 years. Yet the first pilots, I believe, in the UK were done about 20 years ago. MAPs add to the breadth of skills within multidisciplinary teams. I'm not sure I quite agree with that, but we'll come back to that in a minute. To help meet the needs of patients and enable more care to be delivered in clinical settings. PAs do not fall under the allied health professions, AHPs, or advanced practice group. Now, just in case we don't revisit it, and this might be the place to talk about it, this idea of adding to the breadth of skills within an MDT, I'm not sure actually that goes without saying, because when you employ an associate professional and the model of the associate professional training, they're not by definition adding new skills to the skill mix of whatever team you employ them in, because all of the associate professions are kind of defined by being an abridged version of the training of something else. You're not introducing a new skill. If you required all PAs, for example, to be paramedics or to be intensive care nurses or to be psychologists or something defined before you then employed them in your team, I think you could make that point that they add to skill mix, but I would actually argue that by definition, by virtue of what the training is, you're not broadening the skills that are in your team. You're just getting another person in with a subset of the skills of the other people that you already have in your team, if that makes sense. So titles and introductions, it's important that PAs take all reasonable steps to inform patients and staff of their role and to avoid confusion of roles. Seems sensible. This includes considering the potential for verbal and written role titles to be misunderstood and taking the time to explain their role in any clinical interaction. That's great. So it's our view that when a PA introduces themselves to a patient or staff member, they must make it clear at the start of the interaction that they are a physician associate, as well as explain the use of the term PA as a recognised abbreviation of the title. Yeah, that seems reasonable, I think, to identify that physician associate and PA are linked in that way, because obviously PA, I think in the UK, has a much more common meaning, which would be personal assistant, right? So actually making it clear to patients and other staff members that physician associate and PA, the abbreviation, are linked in that way is probably quite important for everyone. PAs should offer patients and staff the opportunity to inquire more about their role, taking sufficient time to explain the role, including training qualifications, that they are not a doctor and that they work under the supervision of a named senior doctor and within a consultant GP employer approved scope of practice. Again, I think that's really good. I think, will it be tiring for PAs to do that repeatedly and potentially quite frustrating? Yes, I think it could be. However, on the balance of things, that is better for safety, that clarification is made, especially when it has the word physician in the title. Physician obviously meaning doctor. Historically, I think if it has the word physician in it, especially the word associate as well, where the word associate, again, I think in the UK, implies that you are qualified in the domain in which you are working. So for example, a legal associate, I would expect to have a law degree. In this case, where PAs don't have medical degrees, I think that clarification is a good idea. Qualifying that they're not a doctor and work under the supervision of a named senior doctor, again, I think that's good. Even I, as a doctor, as a more junior early careers doctor, clarify the name of that senior supervising doctor that I work under. You know, my name is Ollie or Dr. Burton, I'm one of the neurosurgery doctors. I work for Mr. X or Miss X. Patients want to know who the boss is. That's what Scarlett McNally's research shows into patient preferences for titles and how we address people in hospital. And within a consultant and GP/employer approved scope of practice, again, coming back to what I've said before, it's probably a good thing to spell out, although I'm not sure it necessarily means anything, given that there is no formal defined scope of practice, as it seems to be down as individuals. I'm not sure how much value that gives to the other person that you're talking to, because they presumably won't know what that scope of practice actually is. The time required for this to take place in detail should be factored into any consultation times. Good, because it ensures that it will be done every time. PAs must correct patients and staff if they refer to them as a registered doctor, nurse, or other professionally protected role title, including verbal, written, and other forms of communication. Again, good. I know that this is a bugbear that happens especially in settings like GP a lot, where other healthcare professionals that aren't doctors, patients will often well-meaningly call them doctor, even if the person has made clear that they aren't. That assumption is made in, say, a GP practice that the person the patient is talking to is a doctor. And again, it's good, I think, to make that recommendation to correct patients. It doesn't make the assumption that the PA in this instance has been negligent in explaining their role or lied to the patient or obfuscated anything in any way, but correcting patients when they do make that mistake is important, because it's really important for patients to know who they've seen and who they haven't seen, especially when they're chasing up their own care. So we recommend that PAs, employers and organisations should not use the following terminology when referring to PAs and the PA profession. So trainee, again, probably a good idea. Trainee in medical parlance means a specialty trainee, that is usually going to be a registrar, so someone actually quite senior. It's really interesting and weird how different professions use terms like student or trainee, and for the very same reasons we wouldn't call medical students or student doctors, we wouldn't call them medical trainees, because a trainee is a qualified doctor that is training in a specialty. I've not ever heard of a student PA or a PA student, whatever you want to call them, being referred to as a trainee PA. but it's such a can of worms that the decision to avoid that is probably a good one. Foundation, again, foundation doctor, somebody who is a qualified doctor but not yet in specialty training. I don't know really in what setting a PA would be referred to as a foundation PA. Specialist or specialty PA, now that one is interesting because I don't know what the mechanism is going to be or the way of recognizing that a PA has built up a certain number of years or a certain amount of experience in a specialty, right? I think it would be fair, for example, to call someone, a hepatology PA or a PA in obs and gynae or whatever, because that's what they are. But calling them like an obs and gynae specialist or an obs and gynae specialty PA, it just gets a bit too close to specialist doctor or specialty doctor, because again, specialty doctor has a particular meaning. That is the other SAS contract. And then consultant, obviously consultant is the really hot word that people get very annoyed about being used for non-doctors. It causes enough problems, the word consultant being used for non-doctor professions in healthcare anyway. I think not adding PAs to that discussion, again, on balance, is probably a good idea. They probably will need some other way of delineating a very senior PA or a very experienced PA, but consultant is not the best word to use for that. So the FPA's provided an example of an introduction that PAs may wish to use within their practice. So they might say, hello, my name is Joe Bloggs and I'm one of the physician associates working in hepatology. Physician associates are commonly referred to as PAs. I work alongside the doctors, but I'm not a doctor. Yeah, good. Non-objectionable, really. So then we get on to titles. They do not recommend the use of prefixes in clinical interactions, notes or letters. They must always use the full title of physician associate when first interacting with a patient or staff member, followed by the specialty in which they work. This is to ensure that patients hear and know the role title and abbreviation first, followed by the specialty. I like that. I think that's really sensible, actually, because it puts that identity of the staff member, the person that patient is interacting with, first before the role. I think that's a good way around. PAs must not use protected titles or abbreviations which imply they're registered with the GMC as a medical doctor. They must not use the prefix doctor or title doctor in any clinical environment or interaction with patients, and this could be confusing or misleading for a patient. Agree. Look, I think this is the thing really that doctors are worried about, and it's obviously part of the reason why the GMC was set up in the first instance and why several terms were made doctor only, to ensure that a patient knew they were being seen by a qualified and registered doctor. Doctor of Medicine is a legally protected title, and the public would reasonably assume that anyone introducing themselves as doctor in a healthcare setting meant Doctor of Medicine. Agree. I think overwhelmingly, this is what our experience tells us, and it comes back to what I was saying, that patients tend to assume that the person they're seeing is a doctor, rightly or wrongly. As well as verbal interactions, this guidance applies to written clinical notes, letters, websites, social media platforms where people identify themselves as a PA, that's interesting, or any work relating to clinical practice or interaction with patients. So that's very wide-ranging, goes across the whole gamut there, and would include the private sector as well. Like, it goes as far as any clinical interaction with patients. This is a good thing, I think. It is protecting the public, or this is a move towards protecting the public from thinking that they're being seen by a qualified doctor when the person might not be one. PAs who hold an accredited and recognised level 8 equivalent doctorate degree, I know several PAs that have PhDs, and work in academia can use the prefix doctor or title doctor when working in an academic context. I don't think anyone really objects to this. The FPA advises that PAs using doctor in an academic setting should use their post-nominal qualification to identify their qualification. I'm not quite sure whether that means PA or like PhD. You should probably do both, right? PAR, PhD would make it very clear. PAs should not use prefixes such as Mr., Mrs., Miss, MX in any verbal clinical interaction with patients, notes, letters, websites, etc., the same domains. This is a prefix that is traditionally associated with a surgeon in clinical settings in the UK and could be confusing or misleading for a patient. Now that is very interesting. And that, I think, actually goes potentially a bit far the other way, because the particular problem with that is that Mr., Miss, Mrs., MX, whatever you wish to use, that is the default, obviously, that everyone uses in the UK, even in a healthcare setting. And I'm surprised that this document goes that far, because as much as I think that is true in surgical settings, if you were working in a neurosurgery department or a, I don't know, plastics department or something, and someone referred to themselves as Mr. or Miss, then yes, I think the default understanding would be that they were a surgeon if they were having something to do with your clinical care. However, if you were working in a medical specialty where there was no expectation that the patient would be seeing a surgeon for whatever their problem was, I wouldn't say that the default assumption if someone introduced themselves as Mr. would be that they were a surgeon, because there wouldn't be any reason for them to be a surgeon there. I mean, like, good on the documentation for going that far and clarifying that position. I think that's very thoughtful of them. I'm just surprised that they've taken it that far. PA should not use titles or abbreviations that may confuse patients about their role, e.g. GP physician associate, GP PA, or PA surgeon. Yeah, I think that's wise, because those specialty terms, such as saying GP physician associate, because it's got GP at the start of it, GP stands for general practitioner, not for general practice. And again, the example they've given is PA surgeon. Surgeon has a specific meaning, and the only people that are allowed to identify themselves as surgeons are people that are members of the Royal College of Surgeons that have passed the MRCS A and B. That is what makes you a surgeon in UK parlance. And ideally you would also be practicing surgery as well. They've then given some examples of standardised ways of using their professional titles, so forename, surname, postnominals, physician associate in cardiology and respiratory medicine, whatever, managed voluntary register number, and then employer name. Great. I think this is fine, right? This spells out very clearly what someone's name, role, specialty, and qualifications are. Great. At the time the GMC opens a register for PAs, those who get GMC registration should include their GMC number below in replacement for their managed voluntary register number. Now, the only thing I would say about that, and again, something I think a lot of doctors are quite wary of, is I am of the opinion, and I think many doctors are, that there should be something about the GMC numbers when PAs join the GMC register. There should be something that separates doctors' GMC numbers and physician associates' GMC numbers, like it should start with PA or something like that. I don't think everyone having a kind of uniform set of GMC numbers is a good idea, because it comes back to that idea that a patient should be able to tell exactly who is looking after them, and if they say give me your GMC number, they should be able to tell from that information who they're talking to. So comparison to other professions, PAs are not medical doctors trained to provide care as a PA with supervision from a senior doctor, that being a consultant or a GP. The FPA is aware that non-doctor healthcare professionals have been compared to seniority levels of a doctor, and that PAs have been compared to this and other professional groups from an organisational perspective, including referring to PAs working at FY1, Senior House Officer, that would be an FY2, or Registrar level. The FPA recommends against this for PAs. This is really solid, and I'm really pleased to see this from them. It is incredibly irritating for doctors when other healthcare professionals are compared to their level of kind of training seniority. And this isn't a PA problem, by the way. This happens with many different types of healthcare professional, and it's just a little bit reductive, essentially, because doctors' training is so much longer, relatively speaking, than virtually anyone else's is to get to where they need to get to. It can be a bit insulting to have that training experience, long hours, sacrifice, all of that kind of condensed, and for someone to go, this person is the same seniority as you, or is working at your level despite not having the years of experience and training that you have. No one likes that. So it's really good, actually, that they are recommending against this. PAs work across the breadth of healthcare, providing care to patients and supporting the wider MDT. They're not in a postgraduate medical training program and are commonly employed to work in a specialty area. The tasks and responsibilities of a PA working in one area may differ from those in another, making it difficult and confusing to make any comparison to medical or professional hierarchies. Good. Very insightful, I think. The FPA does not believe it's helpful or effective to compare PAs to a set seniority level of a doctor or another professional group. Good. The FPA will soon publish a career development pathway for PAs which will detail the potential seniority levels to which a PA could progress and the expectations at each level. The FPA recommends that PAs, employers and organisations use this pathway when explaining roles and seniority. This comes back to something that I've written about before, actually. In a published essay, I wrote about PAs for a recent essay competition, which I ended up winning. And I do think it is important that PAs have a defined career progression, because you won't keep them otherwise. All healthcare professionals need career progression. Now for PAs, I don't know what that will look like without stepping on the toes of medical trainees and other groups like ACPs, other advanced practitioners. I don't know what this is going to look like, but I think they need something that allows them to remain clinical and get that career progression and advancement without being forced into management, because that's what happens with nurses, and it's terrible. It is a terrible, terrible waste of skills and expertise that nurses are forced to go into management in order to get a pay increase and get career progression. So PAs will need something. That much is clear from the information we already have. And then the last bit is just talking about the Medical Act. So the Medical Act of 1983 is the piece of legislation that governs the regulation and credentials of doctors in the UK. And it's basically illegal for anyone to portray themselves as a medical doctor or a medical practitioner when they are not. And then it gives a list. So Doctor of Medicine, General Practitioner, so GP itself is a protected title. Surgeon is protected, physician is protected, licentiate in medicine and surgery, which no one uses, Bachelor of Medicine, so that's the degree, apothecary, this is a historic thing, through the Society or Worshipful Company of Apothecaries, or whatever they were, one of the old London trade schools, I think, or any name, title, description that implies they're a registered medical doctor with the GMC. But the long and short of it is basically, do not claim to be practicing medicine unless you are a doctor that is registered with the GMC. I am still really fundamentally stuck on whether PAs are thought to practice medicine or not. And if you are a PA watching this video, I don't know what you perceive yourselves to be practicing. I emailed the GMC about this myself, and they weren't able to comment on whether PAs practice medicine or not because they don't regulate them. The GMC's view, as far as what they have on their website, is that in order to practice medicine, you have to be a registered doctor with the GMC, which I would take to mean that at the moment, PAs don't practice medicine as they wouldn't meet those criteria. But what you would say a PA practices, I don't know. And whether the GMC's view on whether PAs practice medicine or something else will change when regulation comes, I honestly don't know. It's a bit of a semantic minefield. But yes, that is the document. Sorry it's been a bit of a rambly video, but this is important, it's interesting, and I think we need to keep everyone abreast of what's going on in this space. So let me know what you think down in the comments. Take care.